Let's start with a case, okay? This is case management. First of all, objectives. Why is multidisciplinary care important? To discuss why patient-centered care is important and to recognize patients' goals of therapy. Corey will do the latter two, and I'll start with this. The case is a 24-year-old woman presenting with steroid-dependent ileal and perianal Crohn's disease with a small perianal abscess. That's just to get our surgeons riled up. The workup reveals deep ulcers with narrowed ileocecal valve, a small perianal abscess and fistula. She's iron deficient, osteopenic, and vitamin D and B12 deficient. She now lets us know that she wants to get pregnant soon. We invoke on shared decision-making for combination therapy after surgical drainage of her abscess. Now let's talk about the logistics. Starts off with a surgical consult with drainage and ceton placement, and then we need to prepare for combination therapy. She gets her quantiferon, hepatitis B, thiopurine methyltransferase measured, and of course it takes about a week to get these outside labs and find them in our charts because they don't go within our computer systems. Her quantiferon is positive or indeterminate, so she gets an infectious disease consult, is put on INH for 6 months, requires monitoring for that, whoever's going to do the monitoring. Preparing for biologic therapy needs an influenza vaccine, pneumococcal vaccine, HPV vaccine. Who's responsible for doing that? We have to initiate insurance approval, specialty pharmacy versus infusion center to do the approval, or is it our offices to do it? Let's continue with these logistics. She started on combination therapy, initiated on azathioprine, monitoring, blood count, liver functions. How often? Weekly, biweekly, or monthly, or 3 months once she's on it. We need to adjust the dose and continue monitoring. We're going to initiate biologic therapy and consider therapeutic drug monitoring. When should we be doing the monitoring? How should we be doing the monitoring? How should we adjust the dose? We want to escalate the dose, we have to call the insurance company. They deny the initial dose escalation because it's not in the labeling. We make an appeal. The appeal comes back denied. We eventually have a person-to-person call and eventually get the dose adjusted. She now needs follow-up monitoring and treating to target. We measure her CRP at what interval? Calprotectin, what interval? Colonoscopy, when should we do it first? And the repeat imaging, when does that happen? She does improve and returns pregnant. We have to go through shared decision-making regarding ongoing therapy during pregnancy and lactation. We consult with her OB-GYN to get their approval for whatever the therapy. She decides to continue on the therapy through treatment. We decide what kind of delivery. She's had perianal disease. Does she get an opportunity for a vaginal delivery or a C-section? We need to engage the OB-GYN. She stays on TNF and azathioprine therapy. We alert the pediatrician, the neonatologist, that the patient is on combination therapy and the baby will be exposed. What are the leftovers? Well, she needed an endocrine consult for osteoporosis. We needed to replace and monitor vitamin D and B12, replace and monitor her iron deficiency anemia, arrange for IV infusions if she doesn't tolerate oral iron. She comes back and she's lost insurance and has stopped the biologic because she can't afford to pay. She relapses, has no insurance, and develops a bowel obstruction and needs an urgent ileal resection. How are we going to do the postoperative monitoring and postoperative therapy? Should she be, since she has no insurance, should we be considering a clinical trial for her in this situation? Pointing out the complexity and the logistics of taking care of almost any individual IBD patient that we've seen. We invoke surgeons, obviously, because within the first year in what's known as the REACT study, where patients were treated to aggressively increase or accelerate therapy, despite early combined immunosuppression, nearly a third of patients go to surgery within the first 2 years. So obviously surgeons are our partners in this. How do we manage the extraintestinal manifestations? The skin manifestations, eye, bones, and joint, as I've already alluded to. We invoke our subspecialists and our consultants to do this in this team effort. And then what about monitoring the quality of care? Gil Melmed has looked at whether or not clinicians and caring physicians are monitoring the patients for all of the different quality indicators that we've invoked. The clinical assessment, well, that's the gastroenterologist. Bone density, who's doing that? Is that the endocrinologist? Immunizations, is that our primary care, or are we responsible? Who's doing the monitoring and interval assessment? Those are our nurses and advanced practitioners. The patient gets thrombophlebitis prophylaxis. That's done by hospitalists in the hospital. And then tobacco cessation, which we think is one of the most important things in Crohn's disease management. Our responsibility, primary care, who takes care of that? Ray Cross will be talking later about telemedicine in IBD in our medical homes. How are we going to be organizing this? What are going to be the logistics of setting up and monitoring patients at home during this time? So the complexity and logistics of IBD care start from the primary care physician for health maintenance, our pediatricians with transition of care and certainly care of the young children, our gastroenterologists, and our team within us, the dietitian, advanced practitioners, our essential nurses, our medical assistants and liaisons, our pharmacists, our specialty pharmacists, our infusion centers, our social workers who are doing resource utilization, our behavioral therapists who are helping with self-efficacy, as we're going to hear, and our clinical research staff who are trying to enroll patients into trials where nothing else is working. It takes multidisciplinary care to take care of our IBD patients. And now Corey's going to tell us how to individualize that care. Thank you.
Thanks, Steve. You set us up nicely to think about multidisciplinary care. And I'm pleased to share this talk with you, which happens to be the title track of the whole conference, which is about multidisciplinary care and patient-centeredness. So although we do need a team of dedicated providers necessary to properly care for our cohort of IBD patients, this is really about individual patient care. And when we talk about patient-centered care, I know we all think we give it and we all try to give it, but we need to understand exactly what we're talking about. It's not just about thinking about taking care of a patient at the center of this universe that Steve describes, but it's about understanding what our patients need and want out of their care. And if you look at the Institute of Medicine definition for patient-centered care, it's about providing care that is respectful of and responsive to individual patient preferences, needs and values, and ensuring that patient values guide all clinical decisions. It sounds simple, but it's not easy to do this in a busy clinic when you're 45 minutes behind and you've got people lined up coming in and you simply know they need to go on combination therapy to treat them, but trying to understand all of this in a short period of time is very hard. So we have to keep a few things in mind. First, just don't forget of the concept. Remember when you're sitting in front of a patient that we need to think about what they want and how that should guide us, as opposed to what our algorithmic care in our head would guide the next possible therapy and what you would do. You need to understand what your patients want for their role in their decision making. Some don't want much, and others want a huge amount of participation in what they're doing. And then we have to learn about our patients' values, what matters to them at that moment, and that might change over time. And again, this is all hard to do when you're busy and patients have a lot of things they want to discuss with you, and you have a lot of things that you want to discuss with them. So you need to mesh your patients' goals, who are experts in their disease, far better than you're expert in their disease, but then bring your expertise and how to best care for them together, as opposed to coming at from different angles. The way to do this, or one way to do this, of course, is around shared decision-making. We use the term loosely, I think, which is really meant to say there are two people that participate, but we need to understand that there is a specific definition here that we're working with, which are talking about patients who want to be involved with their healthcare providers in making shared medical decisions. Not all of our patients want to be. There's a real range in the type of decision makers when we're seeing patients in the office, and this idea of patient-centeredness should apply to everybody. But the idea of shared decision-making doesn't necessarily apply to everybody, because there are many patients who want to have a passive role in their care where they're really the recipients of your expertise, and they'll tell you about their symptoms, but they don't have much idea of what they want out of their care, what their goals are, probably because they need some education around what their goals should be for their treatment of their IBD. Then there are many patients who want this active role, and you know who these patients are. They come in with literature already printed out and a plan for what you should be doing at that visit and what their goals are over the next 6 months. And that's good too, but really the best way to engage in this process is of course where most of our patients are on this spectrum, which is the collaborative role of working together with your patient, understanding their values, let them guide you for what their goals are, and then you help them achieve those goals. Most patients want to take part of shared decision making, but some patients simply don't, and this is looking at patients across all different disease states, and you can see that about a quarter of patients don't want a part of this. They just want to give it over to the doctors, and they want their providers to guide them through their care, which is okay, but you do need to recognize that as opposed to trying to pull out of them what their goals are. But if you think about IBD patients in particular, this is some work that we did at Dartmouth, that almost 90% of IBD patients say that they want a big part in the decision making. So please recognize in your IBD patients probably a very special group of patients who are engaged, activated, smart, that they want to take part in their care, and make sure that you give them the opportunity to do so. It's time for a couple of definitions that are important, because patient-centeredness, shared decision-making, patient activation, patient engagement all sound very similar, but they have specific meanings. Patient activation is what your patients are up to in their understanding of how aware they are and taking part in their care. It's the understanding of one's role in the care process and having the knowledge, skill, confidence to manage one's health and healthcare. And I'll show you some examples of what we mean by that. Patient engagement's a bit different. Patient engagement are the interventions that you and others create to allow your patients to become more activated. So for the next few slides, I'll really be talking about patient activation. How can we get our patients activated and part of their care? This isn't just getting them to be adherent to therapy, as Susie has told us is so important, and not just telling them what to do, but again, having them part of it, bringing them into the equation so they're part of their own care. You can look at different levels here of where patients are, whether they're at level 1, 2, 3, or 4. It starts with just understanding their medications and knowing what they're on. If your patients don't even know what they're taking and why they're taking it, they are not activated in their care. But as you go down the list here, it becomes more complex. They understand when to call for problems. They understand what's the difference between an emergency and what's not an emergency. And then when you get to the lower levels, down to level 4, they actually know how to problem solve on their own and not run to the emergency room every time that they have abdominal pain or fevers, where you know they're going to get a CT scan, corticosteroids, and probably narcotics. Is helping our patients be activated enough in their care so they know how to keep themselves out of trouble, and then if they get into trouble, how to keep themselves out of getting into even deeper trouble, which is going to the wrong place for the management of a chronic disease. Why is this so important? Well, across all disease states, they've shown that improved patient activation improves patient outcomes. It improves the health experience so that more activated patients actually report more positive care experiences and have fewer problems with care coordination. And it actually lowers healthcare costs. There's a direct correlation between activation, I should say an inverse relationship between activation and healthcare costs, and the more that you can engage and activate your patients, they're better going to do, and the cheaper they're going to be for the healthcare system. Can we increase activation levels, or is this something that you're just stuck with, that patients are inactivated and you can't do anything to change it? But again, across many different disease states, that evaluation of interventions can increase patient activation, have consistently shown improvement in these patient activation scores. But more importantly, and beyond that, that they've shown improvements in quality of life, health outcomes, objective clinical outcomes, adherence to treatment, reducing symptoms, reduced hospital admissions, and reduced use of the emergency department, which I already commented is so important. So this idea of activation is not just something that's better, that's going to make your interactions easier, but actually will improve their health and improve their long-term health outcomes. We have to understand our individual patients' goals of therapy. And this is a big part of the idea of being activated, is to have them tell you what you're looking for. I'm sure at this meeting we'll have discussions about the differences between mucosal healing in histologic healing, and that's for us to figure out. That's for us to guide care and set goals for ourselves. But I'll tell you that our patients aren't walking around concerned that they don't have histologic healing, so they better increase their trough levels so they prevent antibodies so that they can get all better. What our patients really want is this. These are some of my patients. You can tell where I'm from in New Hampshire just by looking at what they do for their fun. That these are patients who are really struggling that sent me pictures doing the things they love to do. For them, this is what their goal of therapy was. It had nothing to do with mucosal healing or histologic healing. It was getting their quality of life back to a point that they can do the things that they love. And it made me think about this a little bit more around, for anybody who took their Psychology 101 class in college, you might recognize this as Maslow's hierarchy. Maslow's hierarchy, if you remember, was first, people needed to feel safe and have good health and be able to have a home and a place to live, and then only towards the top of the pyramid do they get to self-actualization and feeling efficacy in their own lives. I think IBD is the same for our patients. If we're talking to them about mucosal healing, treating to target and trough levels, but you're ignoring the fact that they can't go out of the house, that they're having accidents at night, that they're scared to take a job that needs travel, we have a lot more work to do than just think about histologic healing. And please think about where your patients are on this grade here of what you should really be focusing on in their care. Don't let the perceptions that you have get in the way of good care. We all find that patients come in, you know what they need. You know that they need good early intensive therapy, whether it's with biologics or combination therapy, but we worry that we're gonna have this big pushback about fears of side effects. You're gonna have this long conversation about lymphoma and timing of drugs and how you treat them. But we found that when you actually ask patients what they're worried about, I thought the number one answer to this survey that we performed was going to be side effects of drugs. But look what patients with ulcerative colitis are really most worried about. It's losing their colon and having colon cancer. Down the road, only about 14% of patients said that having adverse events to medications was their number one concern about their ulcerative colitis. But I think that patients come in and often we think that they're going to be scared of these medications. Therefore, we draw back. We don't really push what we think they really need. But please keep in mind that our patients are worried about their disease getting worse, more so than they're worried about the side effects of their medications. So how can we be more patient-centered? What can we do to make this a little bit easier without taking an hour and a half to try to figure out exactly what their values are? Well, you can just ask them. Dr. Hanauer taught me that just asking patients, how can I help you with this visit, is one way to do it. As part of our National Quality Improvement Program that we work with the Crohn's and Colitis Foundation, and Gil Melmed and I are co-PIs of, now including 30 sites across the country and growing, we simply ask patients at their visit, what's the number one concern or goal related to your IBD? And we point out that this doesn't have to be related to a specific symptom. It could be about worry about the future or how IBD might impact travel, an upcoming wedding, cost of care. What is it that they want to focus on at that visit? And by starting the office visit with that, as opposed to waiting until the very end, only hearing that they're thinking about starting a family and they're fearful of these drugs, is never going to make it a patient-centered visit. Start with what they're worried about most, and then work on the fine-tuning that you need to do for their medications and other IBD follow-up. We do way too much of this. What do I mean by phone-on-the-shoulder medicine? This is the opposite of patient-centered care. This is where we all are stuck for most of the part of many days, where we're in the endoscopy suite, your pager goes off, the nurse grabs the pager, puts the phone on your ear, and it's your nurse on the phone telling you that Mrs. Smith called and she's flaring. You say, oh, Mrs. Smith, remind me who she is. You hear a little bit about her, and Mrs. Smith said that she was great when she was put on prednisone last time. So you put her on prednisone over the phone. She comes back to see you in 2 or 3 or maybe 4 weeks, and guess what? She's feeling better, and there's not a real motivation at that point to get her on drugs that she really needs to keep her in remission, like biologics plus or minus an immune modulator. And we take things too casually because it's easy to do this, and it takes a lot of time, as Steve said, to work on patient care to really give them what they want. And I urge us all to get away from this easy fix of giving corticosteroids and really being thoughtful about what our patients need and want from us. The number one most used drug in the United States up until last year for inflammatory bowel disease were corticosteroids. If you want to know what the number 2 drug was for the treatment of Crohn's disease, after this many years, was 5-ASAs. There's single-digit percentages being used for biologics across many parts of this country, and we need to do a much better job. The reason is it's very hard. As Steve really nicely pointed out, there's a lot to do every time we want to put a patient on good biologic therapy. We have to diagnose their full extent of disease. We need to have a discussion about risks and benefits and send off all the screening labs that Steve mentioned. We need prior authorization as coverage, which can be quick and it can take weeks. And then once you finally get them in, we have to manage expectations, the follow-up, the logistics, and think about complications. It is hard, and we just simply have to acknowledge that it's hard, tell our patients that it's hard, and have them, again, be part of our team as opposed to doing this independently. To sum up what we've talked about, patient-centered care is definitely the care that we need to be giving to our patients, but you need to think about it, and it's more than just thinking we're focused on our patients, it's really bringing our patients into the equation. Patients are at very different levels of activation and have different desires and needs, and we have to think about what that patient needs and how we can bring them up and get them as activated as possible so that we can improve their care and their outcomes. We need to spend time at understanding your patient goals. I would argue that that's more valuable than all the details from what happened in their IBD in the 1980s, as opposed to what you're deciding now. We need to understand what they want out of their care and what their biggest concerns are. And as Steve pointed out, that you are not the one that's going to be most important to their care, it's your team. And please engage your team and take good care of them, because without them, we're totally going to be lost. So thanks for having me. We really appreciate being here and the opportunity for this conversation.